That's me again, Kelly Phelan. I'm a nurse practitioner at Dalhousie University in Halifax, and I don't know how many people we have on tonight, but I'm excited. I think we have 59 participants. That's pretty awesome. And we've got nurses from all across the country who work with patients with inflammatory bowel disease, and welcome to you all. Next slide, please. I want to first thank our silver sponsors, AbbVie, Amogen, Pfizer, Takeda, and Viardis. Thank you very much for sponsoring CANIBD and helping us fulfill our mandate. Next slide, please. So CANIBD, so it's a community of practice for nurses working in Canada in the field of inflammatory bowel disease. A lot of us were doing this very independently in pockets all across the country, but CANIBD has enabled us to come together as a group, to build things as a group, and to share things as a group, which has been really important. And nurses, we believe, are a huge part, an important part of the multidisciplinary approach in the treatment of patients with inflammatory bowel disease. Nurses, I believe, have the strongest role in chronic disease management. And of course, Crohn's and colitis are chronic diseases. So we have a huge role to play, and we as nurses can make a difference. Our vision as a group with CANIBD is to ensure people of all ages with IBD in Canada receive high quality clinical nursing care as part of the multidisciplinary team. So one of our goals is to standardize practices so that in every area of this country, hopefully someday, all patients will have access to an IBD nurse. Next slide, please. Our mission is to improve quality care for people living with inflammatory bowel disease. And in order to fulfill this, we provide support and mentorship for IBD nurses in Canada. Many of you I know have done the IBD nursing mentorship program, and I have certainly mentored nurses. It's a wonderful program. We hope to promote learning opportunities for nurses, provide opportunities for networking, which is really key. And I don't think we fully realized the importance of this networking until we started to come together as a group. We wanted to develop and adopt nursing guidelines, so standards of practice for IBD care for nurses across the country, and elevate the profile of IBD nurses, letting everybody know that we feel it's an important role. We know the patients know, but everybody needs to know. Next slide, please. So our successes, we've had an annual conference for IBD nurses for a number of years now. It's been very popular. I have to tell you, I miss meeting in person. I really miss getting together with my group of IBD nursing friends. We're doing our best virtually, but I do look forward to the day when we can come together as a group. We do an annual nursing-led research grant. We have education webinars for our nurses, patient education as well. And a lot of us are doing patient education in our individual practices, but CANIBD is doing it as well. We have a public-facing website, and we provide research publications by CANIBD nursing members. So that's really exciting. We are having some success. So what are our priorities as we move forward? So we want to conduct a research study to better understand the needs of CANIBD members. So what do our nurses need? What will help them help patients the most? So we want to know what it is you need, and we want to work towards helping you get it. We want to develop nursing education modules. We want to foster greater communications among nursing networks, increase public profile of nursing, strengthen nursing-led IBD research, and ensure sustainability of CANIBD nursing community. So not only do we have to continue to build this community, but we have to believe that it'll continue to grow long beyond when we're no longer doing IBD nursing. Next slide, please. So the current steering committee, there's a list of our current steering committee this year. We welcomed Sajjad Fazal from Ontario. He is with Crohn's and Colitis Canada. Most of the rest of us have been there for a few years, some longer than others, but it's a great group of nurses from across the country who come together to fulfill the mandate of CANIBD. Next slide, please. So a big thank you to two of our steering committee members who we've lost over the last little while. Kathy Arnold-Cormier from New Brunswick stepped down. She was with CANIBD for many years from its inception, I believe, and she was certainly a strong member, and we will miss her. And Emily Cordeau, who worked for Crohn's and Colitis Canada until very recently when she left to do her PhD, has also stepped down, and again, very, very, very highly missed. Next slide, please. In terms of education, what have we done in 2021? So there's been a mental health and resilience building for IBD nursing presentation and a pediatric to adult transition of care and IBD presentation. And these were presented by CANIBD Nurses through CANIBD, and they're just part of the education that we're trying to provide across the country. Next slide, please. CANIBD research. So there has been a fair bit of work, if you look here, publications by CANIBD Nurses. If I missed your name, I apologize. If we missed your research, I apologize. I'm sure this is not a complete list, but this is just a sample of some of what has been done. Next slide, please. Same type of work, more research studies that have been published by CANIBD Nurses. And if you look at these studies carefully, which I did over the last little while, you'll notice that they're very much nursing focused research with nursing outcomes. They look at patients' perspectives, they looked at telephone accesses and email access to nursing, they looked at the experience of living with IBD and the quality of life for patients with IBD. And these are very much nursing driven outcomes and patient experience outcomes. And this research, as all of you may know, can often be very difficult to tease out and difficult to do because we all work in teams. And sometimes it's hard to measure the nursing contribution when the nurse is a part of a team, a vital part of the team, but she's part of a team. But these researchers are making a go at it, so they should certainly be congratulated. Next slide, please. And hello, Kelly Chavez from Montreal, Quebec. Congratulations. You are the Canadian IBD Nurse of the Year Award. This is an award that CANIBD offers once a year. And we are so proud to have a nurse from Montreal accept this award this year. Congratulations, great job. Next slide, please. This is just part of the agenda that we'll be seeing tonight. If you look at it, I'm sure you've all received copies of this via email. We're going to have, first of all, a session on nutrition and IBD that we're all looking forward to, and that is always very popular. And next slide, please. Then we're going to look at biosimilars. And certainly in certain areas of the country, not here in Nova Scotia, but in certain areas of the country, this has become a really big hot issue item. So we're going to have a nice a talk around biosimilars, and I'm looking forward to that as well. Next slide, please. At the end of this talk, we're going to ask you to please remember to do an evaluation. If you don't tell us what you need, it makes it really difficult for us to give you what you need. So please fill out your evaluation, let us know how we're doing, and please send recommendations as to what we can do to further promote the role of the IBD nurse in the country. It's crucial and critical for our planning as we move forward, that we know and get some information from nurses everywhere. And the problem is that there are just so many different pockets of nurses doing this kind of work. And we do this kind of work, but we're in our own little worlds, and we need to understand what your world looks like. Next slide, please. You can stay in the loop with CANIBD. You can stay in touch with us, certainly at the Crohn's and Colitis website. If you go in under the CANIBD pocket, you can look at us there. If you want to email us, there's our email address. There's now a newsletter where a member of CANIBD, every member of CANIBD will receive. And we're all on Twitter now, if you can imagine that. We actually had a session at one point where they showed us how to set up and sign on to Twitter. So we're all, CANIBD is on Twitter, which is wonderful. All right, so I'm going to next call on to, and one more thing I forgot to tell you. So as part of the meeting, if you have any questions, please just hit the question and answer box on your screen, write your questions, and we're going to try to get at them as we can. If all the questions can't be answered, certainly the nutrition ones, we know that we have an agreement that our presenters may go back and answer your questions later or provide your questions in the newsletter, okay? So next, I'm going to call on Melanie Watson, and she's going to introduce our first speaker. Go ahead, Melanie.
Good evening, everyone. Thanks, Kelly. Thanks, everyone, for joining us. I am Melanie Watson. I'm a nurse practitioner. I work in pediatrics in London, Ontario, for those of you that don't know me. And I hope you've all had a chance to eat something, because for the next hour, we're going to be talking all about food and all about nutrition and malnutrition in IBD. So I have the pleasure of introducing our next two speakers. First, we have Julie Cepo. She is the inpatient dietitian with the GI Medicine and Surgery program at Mount Sinai Hospital in Toronto. For over 20 years, her care has focused on nutrition support and therapeutic diet education for individuals living with IBD. She remains committed to sharing her experience through international symposia, program and policy development, research, and publications. Julie's approach is guided by patient and family-centered care, advocacy, compassion, and patient empowerment. So we're very excited to hear from Julie. Following Julie's presentation, then we have the pleasure of hearing from Inez Martincevic, and she is a clinical dietitian practicing within the Division of Gastroenterology, Hepatology, and Nutrition at the Hospital for Sick Children. Inez completed her undergraduate and graduate studies at the University of Toronto, working closely with leaders in clinical nutrition. In collaboration with her gastroenterology team, Inez cares for patients affected by many chronic diseases involving the gut, liver, and pancreas, as well as participates in research endeavors looking to improve diet, nutritional status, and the quality of life of those affected by these conditions. So with that, I will go ahead and pass over to Julie. Thank you.
Thank you, Melanie, and hello, everybody. Inez and I would like to take this opportunity to thank Crohn's and Colitis Canada for being able to speak with you this evening and sharing our knowledge. We're excited about it, and our opinion is that no matter what profession we are, we're united in our care and compassion for patients and their families who are living with IBD. So I'm very pleased to be here and beginning this talk. We have no disclosures. So this evening, we're going to discuss how to approach malnutrition from both the pediatric and adult IBD standpoint. We're going to talk about parenteral nutrition and enteral nutrition as our nutrition support interventions. And then we're also going to speak about diet strategies for pediatric and adult IBD. Throughout our presentation, we'll be weaving a patient case who is a 21-year-old male that is both known actually to Hospital for Sick Children as well as Mount Sinai Hospital. He is 21 years old and he presents with concerns of severe abdominal pain and vomiting. And his reports to you when you're doing your assessment is that he has experienced weight loss, low energy, and very little intake for weeks. So our hope with this case is that as you're going through the information with us, you can relate it to this particular gentleman, who would be a very typical patient that might present to emergency. So simply put, malnutrition is an imbalance between what somebody's taking in and what their needs are. I think what's a challenge for individuals, and especially for health professionals, is how do we find malnutrition and how do we know that somebody's malnourished? So it's not just calories, not getting enough calories. It can also, malnutrition can also be not enough protein or not enough micronutrients like vitamin D or zinc or iron. Malnutrition is defined differently, and as a result of that, it can impact how quickly we react to our timely intervention. And depending on the time it takes for an appropriate intervention, this can in turn affect health outcomes. And we know from working with IBD patients how much they already suffer in terms of the disease from a quality of life perspective. So when we're thinking about prevalence of malnutrition in IBD, it can occur in both Crohn's disease and ulcerative colitis. But it is substantiated in literature that there's an increased risk in Crohn's disease. And that makes sense when you think about Crohn's disease affecting you anywhere from your mouth to your anus. But it's also an increased risk in active disease. When you look at the prevalence ranges that have been reported in literature, it's very high. If you look at Crohn's disease, 2/3 to 3/4 of patients have reported malnutrition. When you look, and that makes sense because anything that can involve the small bowel can impact nutrition very much. In the case of ulcerative colitis, there's a very variable range, 18 to 62%. And when you ask yourself why that is, I think it comes down, and I think Inez would agree, it comes down to how malnutrition is defined. So if there's variability in how research defines malnutrition, you'll see variability in the rates that are reported. I think that when you look at weight loss in hospitalized patients, most of us that have worked in an inpatient setting can relate to this, but 80% is a very high number. I think it's important, the take-home message that I think Inez and I would like you to have from this percentage is that it's not just hospitalized patients that can be assessed. It's the IBD patient wherever they present to you, because they're on a chronic care continuum, whether they're in hospital or in the community, they're still our patients and they're still struggling with some aspect of their disease. Weight loss does also occur in 20 to 40% of outpatients with Crohn's disease. And in many ways that makes sense because there can be a lot of fears that result from the pain or the symptoms that people get when they're eating. And so that can carry on past an inpatient setting to an outpatient setting. This slide looks at many of the reasons for why people can become malnourished. And when you think about it, malabsorption makes sense. There's an issue with the gut. The gut may not be able to absorb what it needs. There can be losses from the gut, be that fluid, blood, electrolytes, nutrients like zinc. There can be medication interactions from things like steroids. And then there's increased energy needs from the inflammatory process. These are medical reasons that can affect malnutrition. And it's important to note that malnutrition is a medical diagnosis. But the role that the dietitian plays has a lot to do with the oral intake of food and assessing and taking a look at all of the intolerance symptoms that can impact someone's relationship with food, a good relationship with food that changes. And that's a big loss for patients. And I have to tell you, when I'm doing my interviews in hospital, often people cry, and it's because somebody is acknowledging with them what they've lost, things that their friends and their family take for granted, like being able to go out and enjoy a coffee somewhere or a salad even when they're with work colleagues without having to explain why they can't have something. So some of the GI intolerance symptoms are things like nausea, abdominal pain, vomiting, and diarrhea. When someone's in hospital, there is a lot of interruption to their ability to get their meal tray, be it for tests or how they're feeling. Some of that's unavoidable. And then there can be prolonged restrictive diets. And I think if you think of your experiences with your IBD patients, at least at some point in time, most patients have experimented with some kind of diet restriction because there's a lot of information out there on the internet or from well-meaning or well-intentioned family members or friends that say, you know what, you've got Crohn's, you can't eat this, you shouldn't eat this. And so they try it because they're vulnerable and they want things to be better for them. And what you eat is something that you have control over in a disease that's chronic. I do want to make note of the fact that active disease or inflammation can lead to anorexia of disease, meaning loss of appetite. And so sometimes I will speak with my patients about the fact that they know they need to eat, they want to eat, they used to love eating food, they put the food in their mouth and then they have trouble swallowing. And letting them know that that's not a case of not having enough willpower, that is the disease, that's anorexia of disease from inflammatory mediators like cytokines. So we know what can cause malnutrition, but why do we care about malnutrition? Why are dietitians and nurses advocating for other individuals in the hospital to consider the impact that malnutrition has on morbidity and in some cases mortality? So weight loss is associated with malnutrition. This is even in the absence of inflammation, and it can result in sarcopenia. And sarcopenia or muscle wasting can be very aggressive in the hospital environment. The concern is that it leads to decreased functional capacity. So when Inez or myself, or perhaps you in your practice are meeting with a patient, asking questions like, Who looks after groceries and shopping for groceries in your home? And have you had enough energy to do that? Who looks after cooking? Have you been able to stand in front of a stove and make something? And in the pediatric case, have you been going to school? These are important questions to figure out whether the loss of muscle mass has been impacting their quality of life. The other big concern with weight loss is that it can contribute to suboptimal growth in children and delayed puberty. Similarly, micronutrient deficiencies for things like iron or B12 can contribute to anemia, and anemia further impacts energy levels. I think the take-home message from an inpatient setting for me in particular is that immune function is altered, wound healing can be delayed, and there can be more post-op complications as a result of malnutrition. So the good news is that there are nutrition screening tools available. So how can healthcare professionals, nurses, or other care professionals get involved? How can you support the nutritional management of your IBD patients? So there are screening tools that are quick, they're not time intensive, and they can be completed by any member of the medical team. And they're meant to highlight patients that can be at risk of malnutrition. And from that point on, there are nutrition assessment tools that people like dietitians can come in and have more time to do because they're more specialized in terms of the questions and the factors that they look at. And what those assessment tools can do is they can define how severe the malnutrition is. And then in turn, give advice to the medical team for how quickly intervention needs to happen. So while studies support the association of screening tools, nutrition screening tools, and assessment tools, there is not a specific validated tool for IBD. So we do need a validated IBD nutrition screening tool, but both Inez and myself are of the opinion that you can create your own tool in your practice and adjust it as needed. This screen is comparing some of the different screening tools that are out there. They are out there and they're available. And if you look at the study that's quoted, it's a very nice review that's applied to IBD. But I think the take-home message from this slide is that the common themes from these screening tools are that they look at anthropometrics, height and weight or weight change, oral intake and whether that's been compromised, biochemical data, which might be something like a C-reactive protein, or even albumin, because that can impact, that is reflective of how severe the disease might be, and also disease status. I think what I wanted to just tell you very quickly is that the nutrition risk screening tool, the 2002, is one that we used at Mount Sinai a few years back with the pre-admission unit nurses, because I was very concerned doing intakes for patients on the unit when they had been losing 40 or 50 pounds. And the question was, how can we intervene, nutritionally intervene with these patients before they come for surgery and have lost so much weight? And the pre-admission unit nurses, from the goodness of their heart, agreed to do this pilot study, even though they had so many other studies that they were having to consent for. And what we found in the patients that were surveyed that had IBD, of the patients that were screened, close to 40% were at risk of severe malnutrition and up to 60% were at risk of malnutrition. So within our own hospital, we were identifying malnutrition before coming for surgery. So sometimes it doesn't need to be a big practice change. It can be something small to identify an issue and then see where it goes. This is a slide of assessment tools. So this would be a more detailed, comprehensive nutrition assessment that, for example, the dietitian could do. And it takes in many factors into consideration that I'll speak about following this slide. So as a dietitian, I think that we can play a key role in further defining the malnutrition that our colleagues identify. So there are multiple considerations. We look at what disease somebody has, whether it's ulcerative colitis or Crohn's, where the disease affects somebody, what status the disease is it severe, is it a mild flare, what area of the bowel and what nutrients might be absorbed there are being affected. We would ask a patient about their height and their weight, but in sensitive ways, like when you felt well, how much did you weigh and how long ago was that? When did your weight start to change? When was the last time you measured your weight? Did you not weigh it because you're upset about the number? And so we can approach that assessment in a very sensitive way, because there are self-esteem issues that result from weight loss, especially with adults, and I would assume with children as well. You probably can think of a patient that shows you a nice picture on their cell phone and they'll say to you, this is who I am, this is what I look like, not this person that's in front of you. So it's very important. This is a disease that many people can't hide when they've lost a lot of weight. Dietitians will ask very detailed questions about oral intake, what types of foods people are eating, why they've made the changes they've had, what barriers they experience to being able to eat more. Sometimes it's money, sometimes it's fear, sometimes it's access, sometimes it's energy. So it's our job to help problem solve that for the patient and their family. We also look at the disease activity and any nutrient deficiencies that the patient's at risk for. And very common ones are iron and zinc and vitamin B12, among others. So if we go back to patient XY, he comes into hospital, you have screened him as high risk for malnutrition. Your dietitian colleague comes and also does a nutrition assessment and is able to diagnose the patient with severe malnutrition. He tells you that he's unable to tolerate food, but he has received parenteral nutrition in the past, and he has used enteral nutrition in the past. He's asking you what you think would be next, what you think is going to happen to him. Think about what you might say to him. So there are two nutrition interventions, and nutrition therapy, generally speaking, is any recommendation that can be made and implemented to restore someone's nutrition health. And often that is by oral intake or counseling with diet, but also it can be enteral, parenteral nutrition to improve nutrition status. Nutrition support, there are two forms of nutrition support. So parenteral nutrition is intravenous and it bypasses the gut. Enteral nutrition, as I'm sure you're aware, uses the gut. So what are some of the considerations with parenteral nutrition? So if your patient is not able to meet their oral requirements or is unable to tolerate enteral nutrition or has declined enteral nutrition, as often happens with the adult population, then parenteral nutrition is an appropriate form of therapy, but it is not considered a primary therapy for IBD. And Inez will get into enteral nutrition, which is considered a primary therapy, but parenteral nutrition is not. When IBD patients are provided parenteral nutrition, there is an association with reduced disease scores, improvement in micronutrient deficiencies, and the result of that, which is improved red cell production, improved energy, there's improved body composition, and there are improved symptoms. However, this is most likely related to the fact that people are not challenging their gut with food while they're on the parenteral nutrition. So some of the reasons why I would see parenteral nutrition in my practice in the hospital, and just to look at the picture, I'm just going to stop to look at the picture on the top right-hand side. So the bag on the left is a 3-in-1 formula, TPN. That's where the lipid, the carbohydrate, and the protein are all mixed together. And the bag on the right is 2-in-1, where the dextrose, carbohydrate, and the amino acid, protein, is in the bag. It's yellow because of the B vitamins, and then the bottle is the fat. And so that gets widened and provided that way. And you might see either form of that. So reasons why I might see parenteral nutrition is that somebody's not able to meet their oral intake requirements or enteral nutrition requirements. They might have GI intolerances that are leading to that inability to meet those requirements. There can be profound weight loss and malnutrition. And I would say in my practice at Mount Sinai, the average BMI is somewhere between 14 to 16, but that's an average. And so currently I have a patient with a BMI of 12, and I might have patients with BMIs that are higher as well. So it is a real problem in Ontario for people living with IBD. Short bowel syndrome is an indication for parenteral nutrition, and there can be death for some patients without that. So asking about surgical resections, asking about how much bowel length is left from your surgical colleagues is really important. People who live with short bowel syndrome try and eat more to try and compensate for how quickly food is going through their system. And that can exacerbate stool outputs either by anus or through stomas. And it also can exacerbate electrolyte and fluid imbalances. So it can parenteral nutrition can play a real role in that setting. It's sometimes temporary for a few weeks or months because we do see bowel adaptation over time. There can be perioperative complications, things like ileus or obstruction, and we use parenteral nutrition in that case. In some cases, when there's a proximal fistula, so higher up in the small bowel, it can reduce in very high output volumes that are rich in protein and zinc. And so we'll use parenteral nutrition and a nothing by mouth diet order to manage that situation until surgery. But I would have to say the indications that I see the most in hospital are an anastomotic leak or gut rest after a perforation where there is a contained abscess or there's a phlegmon or inflammatory mass from IBD. And so the surgeons at Mount Sinai will often use a gut rest approach where they will ask us for 6 to 8 weeks of home TPN, where the patient is only allowed to have sips of water or sips of clear fluids, and it results in a situation where they have to resect less bowel and they're able to mobilize the bowel more easily. There's less of an angry abdomen, as the surgeons say, that results in a better outcome for the patient, even though it's got to be super hard to be asked not to eat for a prolonged period of time. Because of the high risk pregnancy program at Mount Sinai, I do see pregnant patients with IBD who have perforated, who have an obstruction, who've had bypass surgery, and on occasion they will require TPN. And there are specific ways that I have to interpret the blood work as a result of their pregnancy. So for adult parenteral nutrition, there are calculations that I would use to determine the calories that they need based on their weight goals. And all labs need to be interpreted according to their clinical situation because we might see elevations of a liver enzyme like alkaline phosphatase if they've had a perforation. I'm very careful with the thresholds that I calculate for patients so that we're not placing patients at risk of TPN associated complications like cholestasis. And I will sometimes maximize protein to make sure that I'm maintaining calories without giving too much lipid or too much dextrose, which tends in my practice to cause more complications. For pediatrics, it's basically the same concept, but energy and protein is based on the stage of development and can be very variable. It's not as common to see home TPN for children who have IBD or malnutrition, and Inez will continue the talk to discuss a little bit about how that's managed rather than a home TPN situation. So I think we'll do a 10-second break while Inez pulls up her slides, and I'd like to thank you again for the opportunity to speak with you and for your attention.
Thank you, Julie. So certainly as I work on sharing the slides, which is ultimately just a continuation of where Julie had been working from, is talking a little bit more to the pediatric experience, but general sort of ongoing nutritional intervention strategies that we'd like to kind of sort of discuss. So as Julie mentioned, at least in my experience, so I'm going on over 13 years here with the IBD program at CANIBD, I have never discharged a patient home with IBD on home PN. However, and I do get the privilege and the opportunity to connect with Julie quite often in handing over patients or discussing complex patients together, learning about her experience and her nutritional strategies, care approaches, discussions with her multi-D team, notice that there are some significant differences between pediatrics and adult, where in the pediatric world, I have to say we use enteral nutrition quite frequently, quite often. So we do know that parenteral nutrition, and certainly the evidence for the use of it, is in essentially gut failure. Otherwise, the evidence points to, and not just in IBD, but in other GI conditions, to the advantages of using enteral nutrition intervention. So when possible, you want to use the gut. You want to stimulate the bowel. You know, and all this talk about microdiversity and gut microbiome and all that yummy good stuff in there, you want to support it, you want to nourish it, as well as gut health. So there's a lot of interesting data out there with respect to the advantages of EN over PN. In addition to, for those of you who are administrators, there's a significantly lower cost associated with the use of enteral nutrition over parenteral nutrition. But if we're looking at sort of the classical definition, the Aspen definition of enteral nutrition, it is feeding the gut beyond the oral cavity. So a simpler way of looking at it is to tube feed someone. And in pediatrics, we do use tube feeds very, very frequently. Short-term tube feeds ultimately is nasogastric tubes. Longer-term tube feeds is some form of a gastrostomy tube, a G tube, and when needed, we feed post-pylorically. That could be a GJ tube, which is the stoma site, starts at the stomach, extends down post-pylorically. Sometimes it ends in the duodenum, sometimes in the jejunum, or a tube that directly goes into the jejunum, which is usually surgically placed here at CANIBD versus G or GJ tubes, which at CANIBD are placed through radiology. And again, every institution, and I know we're going from West Coast to East Coast, is going to have their own nuances around tubes and how they look. I could give you an entire 1-hour talk on NG tubes, G tubes, and GJ tubes alone. Okay, so I won't go there, but if anyone has questions, please feel free to ask. Now, one of the things that we're frequently asked about in pediatrics versus adults is this concept of using nutrition or enteral nutrition for treatment. And so exclusive enteral nutrition, or EEN, I could also talk about for 3 hours. I won't. It's not the focus of tonight's talk. However, for those of you who don't get to work in pediatrics or who are interested in this treatment but aren't sure how to apply it in adult practice, we can tell you that for pediatric Crohn's disease, as first-line therapy, EEN is considered a choice to offer, and it's a therapy that is quite successful at inducing remission. So what is EEN? Really quickly, for those of you who haven't had a chance to hear about it, you're using, and here's the key, a polymeric-based formula. Polymeric basically means it's intact protein, which means it's not going to taste like garbage, okay? And you're using it for treatment. And that's the key word here, because as we continue to talk about nutrition interventions as well as dietary strategies to help manage patients with IBD, I feel like in my experience amongst families affected by IBD, there's often a huge confusion between what is a treatment goal and what is a dietary goal, and a lot of mishmash and overlap and confusion. So EEN, as I like to explain to families, is a treatment, meaning it is going to work on the inflammation, on the active disease, versus enteral nutrition, which could be tube feeds, is to provide nutrition support to patients that are unable to meet their needs on their own, which essentially means orally. Okay, and that's how I differentiate it for families. Nutrition support or meeting needs for growth, development, for sustaining nutritional status is not the same as treatment. And treatment ultimately is what the whole medical team is trying to achieve. We're trying to get into remission and keep you there. Of course, we don't use EEN as a maintenance because the second key to EEN is that it's exclusively formula. And again, I'm not going to go into the nuances of partial enteral nutrition and some of the other overlapping dietary strategies and interventions with EEN that can be used longer term. But if we just think of it as a classic induction approach, not being able to eat food is often catastrophic to patients. And even in EEN, where I know a patient isn't, quote, starving, it's not that their body isn't receiving nutrients or that they're not satiated. They are just crushed because they miss food. And I mean, I love food. I am not necessarily in clinical nutrition because I love food. I just love food, period. And I can empathize with why a patient would be missing it. And so how do we, help bridge a patient to get to the end of a course can often be a challenge. And that's where a lot of these dietary treatments, which I'll touch upon very briefly shortly, have come to fruition. Why is it that we have been saying for years to our patients that diet doesn't matter, which is definitely not true, but diet doesn't matter and yet EEN works, right? So what was it about EEN that makes it such a good induction therapy for pediatric Crohn's disease? We don't know. What we do know is that its remission rates are comparable to that of corticosteroids as an induction. We do know that the adult data is conflicting, and we do know that in ulcerative colitis, it seems that remission rates are not as effective, and even to that end, Crohn's colitis. Right? So there are nuances about it that really means it doesn't cross-translate to entire populations of IBD and all the different subtypes, but there's something there. We don't know how it works. You got to drink it for like 2 months. If you don't drink it, you got to tube it, when you miss food, right? So advantages, disadvantages, all considerations. But in terms of how it relates to enteral nutrition in pediatrics, because we use EEN as a treatment more often, because we can get away with tube and tube support, I would have to say that our experience of using enteral nutrition over parenteral nutrition is very different than in the adult world, where, even in speaking with Julie, adults prefer TPN. That, if you were to approach an adult patient and say, I'm going to teach you how to stick a spaghetti tube down your nose and you're not allowed to eat for 2 months, they probably kick you out of the room. Okay. Children, I would say, are resilient. They just have an imagination about them. They have a verb about them that's intoxicating. I definitely feed off of it. And they're wonderful to work with. The other thing is it requires a lot of resources. For any of you in your practice that have ever had to work with central lines in the home through the community, you realize all the resources that are needed. Coverage, nursing support, education, anything related to tubes in pediatrics also requires a lot of resources that aren't readily available in the adult world. So that becomes a barrier, not just a disinterest in the approach. But certainly we do use enteral nutrition where it's needed to amend the malnutrition and improve nutritional status in any patient with IBD when it's indicated. Acknowledging that there are certainly different approaches from institution to institution and across the age span. Now, the one area that I feel that any healthcare practitioner can participate with and get involved in is oral nutritional supplementation, which basically means formula. Okay, formula is a great way to, quote, calorie boost, or if you screen for somebody who's mildly at risk of malnutrition, a patient that comes into clinic, they're grumbling along, maybe they lost a little bit of weight, or they tell you, their appetite's on and off, and you're not quite sure, and you want to be proactive because you see that they haven't melted away and that they're not severely malnourished. but you're not quite sure if potentially they could be starting a flare, or maybe there's something else. Maybe they drank some funky water and they might have a gastroenteritis. And so, it might set them off in a sort of a negative tailspin, and you're thinking, how can we stay on top of their nutritional status? You can recommend oral nutrition, which I like to say is in the form of formula, because that's the most convenient, but also people can make homemade smoothies. So this is now using the oral cavity to optimize nutritional consumption, but it's got to also be something that a patient is willing to do and that they're able to tolerate. Because I think what's unique to IBD, aside from other chronic conditions, even if they're autoimmune and inflammatory, is obviously the lumen, the gum to bum. If you are flaring, there could be the potential that you might not tolerate drinking a formula or having more fruit smoothies throughout the day. It might be associated with more symptoms or more frequent trips to the bathroom, which means it may not work for the patient, but it is something that can be advised in a follow-up visit. The one thing too, accounting for the fact that it is not necessarily cheap. So thinking about cost, affordability, and how that might impact the patient or the family is also another consideration. So sometimes for myself in practice, what I do want to know about the family is what resources do you have, what knowledge do you have, and what can I work with to make this work for you? How can my recommendations work for you? It's easy for us to say go and buy Ensure, but not everyone can afford Ensure even if it's on sale. And so thinking about that, I feel like is crucially important. The other thing is you're looking at some of the other macronutrient content. So if you have somebody who, let's say, is more fluid sensitive, you might want to recommend something that's a bit more concentrated, and this is where dietitians can certainly help in letting you know what's available, what's covered, what's generally considered yummy, knowing full on that taste is very subjective. And I've learned that in my journey with EEN. I'd say less than half the patients like drinking formula. And by the end of a typical course, I'd say more than half of our patients are putting everything down the tube. As it relates to then using diet as a treatment, and that's not the focus of this evening's talk, but one thing that Julie and I wanted to mention is that we know this takes up a lot of time and practice. Families, caregivers, parents, friends, teachers, an entire community is talking about what foods you should eat, what foods you shouldn't eat, how to cure IBD, how to get you off your biologics. There is a plethora of information that's out there. I get overwhelmed and consumed by it, and this is supposed to be my area of expertise. So I can only imagine what it's like navigating it if you're newly diagnosed or unfamiliar with how nutrition can either be used to manage symptoms versus treat the disease. As it relates to diets that can be used to treat disease, there is a wonderful new website that I wanted to share with the CANIBD group. Okay, so Nutritional Therapy for IBD is a recent website that I've stumbled across. It's a volunteer-led nonprofit organization led by experts in the GI community that want to share their knowledge and experience of using diets as a treatment. So while we fully acknowledge that the evidence to support the use of diet as a treatment in either Crohn's or UC is limiting right now, I think what's important for clinicians to know is that there's a lot of research being invested in this. And the reason I say that is because you want to share that information with your patients and families. You want to say, we hear you. We would love to, or at least I would. I would love to be able to say to families with IBD, like I do with celiac disease, this is how you eat to stay in remission. It would be ideal, but that isn't the information that we have. It's not the evidence that we have, in addition to other considerations like sustainability around some of these dietary approaches, because they can be a bit intense. But this website has done a great job collaborating and sort of detailing all these different diets, providing you with the references, providing you with those studies at those centers, either in Israel or in the UK, where they used it as a treatment and evaluated biochemical changes, clinical responses, done some neat things like capsule endoscopies, looking at MREs and really digging deep to look for that mucosal healing, you'll find it to be, I at least hope, a useful resource so that you can also let families know that there will be potentially some new information on the horizon. But one thing that I think is a huge take-home message for everyone to appreciate tonight is that even though we might not be able to take a diet and say, if you have UC, eat this way and you'll never flare again, we don't have that information right now. What we can say is that diet is important. It is very important. It isn't about a get out of jail card. Oh, that's a bad Monopoly analogy, but it isn't to say just eat whatever you want and you're going to feel amazing, because that's not true. Those of us that don't have IBD can fully acknowledge when you don't eat well, you don't feel well, aside from the fact that your bowels also don't look so well. So how can we use diet and nutrition knowledge in general practice to help our patients and families with their issues? And this is overall looking at what in general are our nutrition goals. What would we like to do with patients affected with IBD? We want to try to see if diet can normalize bowel function. And we'll talk about this in more detail because I feel like this is confusing. There are many websites out there, and I know I'm going to poke fun at surgeons because I do this here at Sick Kids. They make recommendations on trying to normalize function, particularly post-op, and they'll say, yes, you can now go on a soft diet. And I often joke and say, well, my patients at Sick Kids have teeth, so I don't understand why pureeing something somehow makes it more tolerable post-op, because that's not what it's about. It's not about a texture modification to a diet unless the patient has been assessed by an SLP or OT to say that they have dysphagia and issues around chewing or swallowing. So granted, if you have a patient that has OFG or severe ulcerations in their mouth and their gums are sore and bleeding and they can't chew and they're blistered, makes sense, soft diet. But if you've got all your teeth and or your dentures fit and you don't have dysphagia, there's no need to go on a soft diet. What you want to do is you want to address the fiber intake. So you can use fibers to both decrease stool frequency or improve stool consistency and other modifications that we'll talk about, because it is quite also confusing out there when you're looking at the information that's available both in journal articles and publications, but also online. Is fiber good or bad? I still have patients that I met 10 years ago who tell me their child with UC is not allowed to eat strawberries, and I don't know why they say that. And no matter how much you try to kind of sort of clarify it, I appreciate it can get confusing. The other thing diet can do is minimize GI symptoms. We all get bloated, we all pass gas, we all hopefully pass stools. That's what, keeps us healthy and normal and regular. But in IBD, we're worried about obstructions. So in addition to mitigating these symptoms, because you can have IBS on IBD, you can be in complete remission and still get GI symptoms, which I often feel like is associated with fear of flaring. So being able to differentiate between that is really important. Are you in remission or not? Which will help sort of strategize which dietary intervention you're going to recommend. But these GI symptoms can happen to anyone. You don't have to have IBD to have them, and often what you're eating can impact it. Now, having said that, it doesn't mean that you are guaranteed to have your symptoms improve if you change your diet, because that's really important in practice. Sometimes I feel like some patients and families feel like if you give them a handout with a diet, that this is going to be, the holy grail, and it's going to be the magic bullet that's going to fix everything. And we all know that that's not the case. But in addition to dealing with symptoms, we're looking at hydration, electrolyte balance. This is especially important in anyone who's had a stoma created, whether it's a diversion or an endoleostomy, whether we have a short gut patient. Hydration, and electrolytes is important. Even if you're intact gum to bum and you're flaring with UC and you're passing bloody stool 20 times a day, you're losing a lot of electrolytes, and staying on top of that is important. One thing that gets forgotten in pediatrics often is you need sodium to grow. So I tell all my families, please don't feed your children bland diets. Use spices, use some salt, sparingly, of course, but electrolytes are important in IBD. And of course, we want to improve nutritional status, however that might look, while we're addressing psychosocial considerations. So this is a great review that was put together and published in 2020 by the Eastman Group. So the European Society for Parenteral and Enteral Nutrition created nutritional guidelines for the management of patients with IBD. And I really feel like it's this figure. So notice I took out the prevention. I'm not talking about dietary interventions to prevent the development of IBD in high-risk people. Let's leave that to Jem for now, okay? So you've got a confirmed case of IBD, and you want to know which way you're going to target a dietary or nutrition intervention. And I think this figure captures what can be facilitated in practice. So first identifying if the patient is in remission or not, and acknowledging that most patients, when they're in remission, their risk of malnutrition is low. So unless you have someone with disordered eating, an eating disorder, maybe some mental health issues, other comorbidities that are overlapping with the IBD, it's usually unlikely that you're going to deal with malnutrition. So you're going to reinforce some of those general guidelines around eating well, which we'll discuss for IBD, and maybe target some specific questions. It's often an active disease, and that active disease could be early on, it could be months later, it could be in someone who's refusing medical management, and you're really concerned because you see that the disease is aggressive and it's really impacting nutrition. And I really liked how this was framed, because you've got your kind of sort of dietetic, which is a word that I really don't like. I don't like the word diet. For those of you who don't work with me and don't know me, I loathe the word diet because I feel like as soon as people hear diet, they immediately think restrictions, not allowed to eat bad food. And I feel that developing a positive association with food and eating is important. And so I try not to use the word diet so much, because I feel like immediately people just think negatively with that. So, dietetic recommendations means what are we going to encourage for all patients in general, whether they have active disease or not? And then how are we going to address dietary changes for complications? Okay, so things like obstruction risk or high outputs. You then look at the medical nutrition model, and this would be things like EEN or, Crohn's disease exclusion diet or specific carbohydrate diet. So this is using diet specifically to treat and how that might look. And then you've got your surgical aspects of, nutritional interventions. And this is where it starts to get a bit more complicated. This is where I recruit the expertise and the good brain waves that Julie has around, let's say, dealing with home PN patients that have short gut secondary to multiple surgeries with IBD, pregnant women with IBD, this kind of stuff. Because we really only use PN at sick kids short term and most often bridging to surgery. So you've got kind of sort of this surgical area, this medical area, and then the area that we want to focus on tonight, which is what are you going to tell your patients in clinic? And so moving to the subcategory or like the subfigure, which I felt like really highlighted, for the reader, what are the different scenarios of diets that we can use in practice that might be able to help our patients with the symptoms they're reporting? Okay, so, if you're using cholestyramine or sequestering agents, you can often get sort of like wet flatulence, you can get a lot of bloating, you can get fat malabsorption, and so you need extra supplementation, so this I would say too is less often used in pediatrics. It's more so used in adult care, but you've got sort of dietary interventions that can address that. And then of course, hypoxaluria, which again, we don't frequently see in pediatrics, but if you're dealing with counseling around fat malabsorption, you can develop these, they're basically like big, huge cluster salts that accumulate luminally secondary to bile acids and oxalates and, other goodies that we get from food that grows in the soil and, we munch on. And so you want to reduce those complications. You've we've got patients that have high outputs or diarrhea, however you want to phrase it. And again, that could be out of a stoma or out of the anus. And so how do you address those issues, the fluid needs, the managing the outputs? And then, of course, working with patients. And in this case, this is a bit more specific to Crohn's disease than it is ulcerative colitis per se, but dealing with that stricture risk. And so, I often talk about, fiber being unbelievably beneficial in GI diseases in general. And there's all this information out there about gut health and microbiomes and microbiota and, species differentiation and the role of the gut microbiome and chronic disease and all that fun stuff. And if there's one thing that comes out of the research time and time again is that fiber is important. Fiber is important for a healthy gut. So if you have a patient with IBD that is not at risk of obstructing, so that could be a blockage secondary to luminal inflammation, okay? Or it could be related to stricturing, or it could be related to post-op complications like an anastomotic leak or something like that, then the patient should be eating fiber. Fiber is an important nutrient that nourishes the gut and it feeds the microbiota. But the one thing that I think confuses people is really what is fiber, okay? And if I could define it simply for you all tonight, it's an undigestible. It means the human gut, it doesn't matter if you have a disease or not, cannot digest it, which means it stays in the lumen. And anything that remains in the lumen could potentially block. And so knowing that fiber could potentially block, you have to know the different types. And there's two types. There's insoluble fiber. So insoluble fiber is the fiber that contributes to the bulking and it contributes to the movement. People often think of it as, and I've had many families say this to me, they think of fiber. And so if you think of popcorn kernels, okay, because, we often do say, please avoid popcorn in general if you have Crohn's disease. We've had some horror stories of things that get, dug out from the small bowel when people get scoped. But they visualize like a corn kernel or like a celery stalk, like scratching the innards of the lumen and causing tearing, which is what's causing the bleeding. Okay, that's not what's happening. So I immediately demyth that. And I say, look, it's about forming stool and stimulating movement and peristalsis versus insoluble or soluble fiber. Sorry, my bad. Soluble means it dissolves in water. This is how you remember. Soluble fiber, which slows down transit time and almost gelatinizes luminal contents. And so when you're worried about an obstructive risk, you want to minimize insoluble fiber. So those are the obvious things like peels of fruits and vegetables, no seeds. So this includes seeds that are found within fruits and vegetables or seeds that come from Mother Nature. So sesame seeds, poppy seeds, caraways, which I think has an off flavor. But you want to be aware of membranes as well. So, like the pectin, the white stuff when you're opening up an orange. And anything that has that sort of granular texture to it, like a whole grain oat, okay? That's what you want to minimize. That's what you're reducing. That's what's going to block. But it doesn't mean you stop eating fiber. You still eat fiber. You just eat it in a different form. So you can still have some oats, okay, ground oats. I always tell people put it in a coffee grinder, it kind of turns into like a baby pablum, but it's still very healthy for you. Legumes, barley, psyllium, otherwise known as Metamucil. Okay, this is the kind of stuff that you still want to keep in the diet. Now, the opposite of when you would be sort of altering the type of fiber in a diet is when you're dealing with someone with high outputs. So if someone's got high outputs, whether it's coming out of a stoma, coming out of the anus, you want to do something to form it a little bit better, but you're not necessarily going to be using much more of the insoluble fiber. You're going to be encouraging a lot of soluble fiber still, but more maybe than what you might recommend in general for somebody. Okay, and so managing high outputs, managing loose stools, in terms of diet, in terms of foods that you're eating, you definitely want to focus on starchy foods, okay? And those that are rich in soluble fiber. So you got to think, and I'm a visual person. I always live in a world of analogy. Think about what happens to pasta when you put it in boiling water. It swells, it expands. What happens to rice? It swells, it expands. Why? It's absorbing that water. It's holding on to it. It's retaining it. That's what it's doing to help mitigate those outputs. You also obviously want to consider medications, right? Loperamide is my best friend. I love Imodium in everyone's travel bag too, I'm sure, okay? But in addition to some of the more common over-the-counter medications like Imodium, you've also got things like octreotide, which of course we know is only done on the inpatient side and is given IV, et cetera, et cetera. Okay, you also want to consider that some of these antidiarrheal medications, they work as binders, they're sequesters. Okay, and so the one thing that makes me often contribute to this conversation, if I'm, let's say, on the inpatient side and rounding, is I'm considering how it affects nutrient absorption because they're binders. So you can further compromise nutritional status with some of these medications because of how they act. Okay, then you obviously also want to think about what's going in. Simple sugars drives outputs, everyone. Okay, so things like pop and fruit juice, even Gatorade, guys, sports drinks were made for professional athletes. One of the most frustrating things for me to see is to see a child have Gatorade packed in their lunch. Okay, they're not sweating while they're doing math homework. There is no need for them to get electrolytes back in their body. Okay, and they certainly don't need the blue raspberry G0 no sugar drink, because then all they're filling up with is sugar alcohols, and that's also not needed. So when we talk about using oral rehydration or oral electrolyte solutions, we make a point as dietitians in advising these over those beverages because there are advantages. The type of sugar that's in an OES, okay, is glucose, not maltodextrin, not chains, okay, but actual dextrose, which is easy to target, easily to absorb glucose with a great proportion of electrolytes in them. The other thing we do is we supplement and we use table salt, lemon juice, potassium tablets, whatever else is needed. Another strategy for managing high outputs, and I find I often make this recommendation as a first-line intervention for patients who've just recently had a colectomy, is you want to separate your liquids from your solids. Okay, so you don't want to be drinking, turning your esophagus into a water slide while you're eating, because that's definitely not going to help what's coming out. And now, and I know that I am pressing on time here, but this is the meat and potatoes of the session. This is the step. What are you going to tell people that they should be eating, okay, if they have IBD and they are in remission, there's no active disease, they're not admitted for surgery, they're not admitted from the emergency room, they're just coming to you with a piece of paper from a holistic practitioner in the community showing you 50 supplements they've been advised to take and that they're supposed to eliminate every single food from, the food supply. What do you do with that? What do you do with that patient? What do you tell them? You tell them that you've got to eat well, healthy eating. And I love this. I love that Health Canada changed Canada's food guide to healthy eating because those food groups and portion sizes were impossible to follow. I couldn't do it. How could I expect my patients to do it? This is a much easier approach that parallels the Mediterranean diet. And I like to tell my families, it's not just important for your kid with IBD. Just like it shouldn't be about an adult person with IBD that should eat this way, this is good for everyone in the family. This type of eating has not only been shown to be therapeutic and beneficial in other autoimmune inflammatory conditions like arthritis and lupus or MS, but it actually has been shown to prevent cardiovascular disease risk as well as cancer. So to me, it's a win-win-win. Do it together, eat well, but you got to know how to eat well and what that looks like. And so instead of focusing on portion sizes, we say half of everything you eat, whether it's a meal or snack, needs to be fruits and vegetables. Lots of color, lots of goodies that are fiber rich, antioxidant rich, micronutrient rich, and often low in calories, right? It's Mother Nature's golden, delicious treat to us to stay healthy. Yeah, somehow it seems to be an issue, and you'll see that in the upcoming slides. But in order to eat well, you want to reduce the intake of packaged and processed foods, convenient foods that are often sugar-laden, sodium-laden, and fat-laden, meaning rich in these macronutrients that are of no value to anybody's health, let alone IBD. You want to eat lots of colorful fruits and vegetables, okay? You want to choose whole grains. You can eat fiber if you have IBD, right? Take home message this evening. You also want to consider more plant-based sources of proteins as opposed to just kind of sort of having the Swanson TV dinner, you know, the mashed potatoes, the gravy, the corn, and the steak, you know, the 10-ounce steak. You want to consider other sources of proteins and how you can incorporate them into your diet. You certainly don't want to be drinking anything other than water, and you want to understand your food labels, okay? That is the general message, okay? And it's also what has been shown in the literature. So the figure on your bottom left is one of my favorite figures. That is a pathogenesis paper that was written about IBD specifically and studies, retrospective, granted, a lot of epi studies. So, you know, if you're a statistician and whatnot, you can kind of sort of find some of the gaps in the literature. But in general, all the studies, time and time again, have shown that a Western style of eating is not advisable for IBD. What does that look like? It's the opposite of the Mediterranean diet, guys, okay? And I know we don't live in the Mediterranean. I often make jokes. I wish I could just walk outside and pick a fig off a tree. We live in Canada, okay? So it's not so easy to necessarily apply another worldly diet here, but it is doable because the Western diet, if you look at it, not ideal, right? The bottom of the pyramid is the foods that you want to focus on and the ones you want to eat most. Whole grains, healthy fats, okay, lots of fruits and vegetables. And as you go to the top of the pyramid, those are the foods you want to eat less often, sparingly, you know, once a week, treats. By the way, I don't have an answer for any of you tonight as to how many times someone's allowed to eat a treat per day or per week. So please don't ask because that does not exist. That literature doesn't exist. I tell people to use their own discretion, right? You know, everybody knows that if you eat 12 cookies a day, that's not healthy, right? I don't know if I need to say it and if I need to be so explicit, but I do find that people often want to know that information. So if you look at the Western style of eating, the top of the pyramid is associated with legumes, which pretty much a lot of people in Canada, you know, really don't incorporate into their diet unless they've incorporated food from, let's say, back home where it is a big staple. Because in other parts of the world, legumes are huge, not just as a source of protein, but also fiber and carbohydrates. Meat is often really heavy, lots of sort of, you know, fats coming from either, you know, margarines or you know, drinkable yogurts. Vegetables are very, very low relative to fruits in terms of consumption, but fruits and vegetables are low. There are great public health studies that Health Canada publishes showing you the typical intake pattern of Canadians, and we are well below average in all of the recommendations that were highlighted here. And I say we because that includes me, okay? Touche. And so when I talk about what you want to eat, it's about encouraging vegetables, 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 vegetables. I find I don't really struggle with telling people to eat more fruit, but I definitely struggle with trying to tell people how to incorporate more vegetables in their diet, okay? So we live in Canada. You got to pick things in season or you've got to buy them frozen, ideally not canned because they're often highly preserved, either emulsified or full of salt, you know. So you got to use some frozen stuff and then you've got to learn how to cook vegetables, okay? Because boiling a vegetable is gross. Vegetables are in their best form and their most crispiest texture when they're either raw or if they're just slightly sauteed or maybe steamed or maybe barbecued. But boiling vegetables is a no-no unless you're making a soup, okay? And then you just dump it in your Vitamix and then you slurp it through a straw. You also want to add flavor. Don't forget the flavor and don't forget layering it, you know, like a great example that I often use is, you know, order a pizza. Sure, have pizza. I can't say pizza's bad. Food is not meant to be good, bad, black, white, okay? It's on a spectrum. It's very gray. Order a pizza. Just don't eat 6 slices of cheese pizza. Have maybe 2 and then eat a side salad. That's how you can incorporate vegetables. Whole grains is something that I feel like confuses everyone, including me. I Google whole grains Canada every time I need the definition, okay? Because there's no way my brain's ever going to remember this detail. But I'm going to tell you this is refined grains means you've removed nutrients, okay? This is the white flour that Health Canada then mandates we have to add back folic acid, B12, iron, all these other nutrients. And it doesn't have any fiber. So here's a list of whole grains that are readily available in Canada that people can incorporate into their diet. So I say mix white rice with some red rice or wild rice. How about taking quinoa and mixing it with your rice? Get a buckwheat noodle instead of a regular pasta. Put barley in your soup instead of macaroni. These kinds of things that people can incorporate into their diet. And then, of course, proteins. So proteins, there's a huge trend out there, eating more plant-based. A lot of people are doing it, not just for cultural or religious reasons, but now also for environmental reasons. We know there's a carbon footprint with meats and how meats are processed, as well as how they are transported worldwide. And so in an effort to also contribute to saving the environment, people are trying. I mean, it's super trendy. Come on, A&W's had that plant burger, ripping it up, making millions for them, right? It's super popular. So let's get everyone on that same bandwagon and excited about plant-based proteins, and really truly acknowledging that unless you are very, very, very sick and unable to eat, the typical Canadian person is not deficient in meeting their protein needs. Most of my patients are eating well above their needs. Okay, this isn't a conversation or a highlighting of trying to meet protein needs like it is for vegetables. Okay, people aren't eating vegetables. People are eating proteins, but they're likely more than anything with a Western diet eating way too much animal based. So the focus here is to remind people that whole grains, pulses, guys, for those of you who don't know what the word pulses, legumes, it's always interchanged, beans, lentils, peas, and peanuts. Peanuts are not a nut, okay? Tree nuts grow from a tree, they fall down, you crack them open, you eat them, they're delicious, and they make wicked nut butters. Peanuts grow underground, they're a legume, okay? Just, you gotta love the English language. It doesn't never make sense to me. But pulses, nuts, seeds, these are all things that also contribute to protein, aside from the fact that you can still also use animal byproducts like egg or dairy too. The most popular topic that I have been asked in recent weeks, and I really just wanted to address, is in conjunction with diet. It's supplementation. It's what macro or micronutrient do I need to, quote, make myself healthier with IBD? And this is a huge arena, okay? And I wish I had 3 hours to talk about this too, but I find it's a common question. And one of the things that I wanted to highlight is we know that if you have active disease and if you're severely malnutrition, you're gonna have micronutrient deficiencies. But you don't treat that necessarily with supplementation. First and foremost, on my inpatient wards, I say treat the patient. It doesn't matter how much B12 I'm gonna give them orally, they're just going to lose it down the toilet. It's literally throwing money down the toilet. Okay, so unless I'm treating something like refeeding syndrome, where I have to have a targeted nutritional approach to various different micronutrients of concern, when we're talking about supplements, I find that people feel like they're deficient when truly evaluating the reports and the studies to date suggests that it's really only an active disease. It's often short term because once you're in remission, particularly with small bowel Crohn's disease, you start reabsorbing those nutrients, okay? And it's not necessarily something that you need long term. So when you talk to holistic practitioners and they talk about 10,000 micrograms of B12 is needed in your butt every month, questionable recommendation from my part, we don't see overt B12 deficiency. You're at risk of it when you have IBD, but I often tell families, you know what, let's just measure a level because I also don't feel comfortable recommending a supplement unless I know you're deficient. And if it's around inadequate intake, so if somebody says to me they're worried because maybe their child's a picky eater, or maybe they themselves, have decided they're going to be vegan because Gwyneth Paltrow is, then fine, you know what, I can certainly provide you with recommendations, but they're very generic. The micronutrients that I would say need to be highlighted though in IBD time and time again is iron, and we know that that's medical management. Calcium, I can certainly speak to children, and there's wonderful reports out there. Dr. Leanne Ward has done some great work in Canadian children and adolescents. They're not meeting their calcium needs from food, not at all. Short of you being, I don't know, under the age of 6, where you're still drinking 2-3 cups of, either cow's milk or a plant-based fortified beverage, nobody's children are meeting their calcium needs for growth and development. So absolutely, you need a calcium supplement for that. You need vitamin D, because we know that it's not only important for bones, it's important for immune health, and you definitely need iron addressed. But other than that, K, folic acid, zinc, not folic acid with methotrexate, mind you, everyone. I'm talking about supplementing diets, okay? In Canada, our flour is mandated. Wheat flour is mandated by Health Canada to be fortified. If anything, when we measure red cell folates in our patients, they're through the roof. We're dealing with high levels, not deficiencies. But what I wanted to highlight is you want to treat a deficiency and you want to treat it appropriately. So maybe at your specific institution, you might have PO or IV strategies. And you might want to consider a multivitamin. So when you're not worried about a patient that's overtly malnourished and you think, really they're just in remission and they kind of want to know what supplement they should take, you can tell them that a multivitamin certainly is safe. It's relatively benign and it gives them more of the micronutrients they might be worried about. So you just need to make sure that the multivitamin has zinc in it and selenium and B12 and some of these other nutrients of interest. And then as it relates to non-micronutrient supplements, there is really, really good information in that Eastman 2020 paper about, omega-3s and turmeric and probiotics having zero therapeutic benefit in IBD. Okay, so if ever a family is asking me about these supplements, I tell them that they are adjunctive, they are complementary, they are relatively benign, unless, probiotics, we're worried about bacterial translocation, central line infections, post-op. There might be specific situations in the short term where we won't advise it, but in general, overall in IBD, to support gut health, by all means, if you want to pay the money and you want to supplement, you can. Dosing, however, is the one thing that is not clear. So I do tell families, especially with turmeric, you can cook with it, but you're never going to get the same amount of active biophenols as you do in a capsule, right? So I tell the families to follow the instructions for age on the label, because ultimately it having zero therapeutic value, there are no dosing guidelines, So you just want to be mindful that too much of anything in nutrition is also not a good balance, right? I often have to remind individuals that you can be obese and be malnourished. It's not about your size, and bigger isn't necessarily always better. In the adult world, there have been great published reports on individuals who started eating the Mediterranean diet. Everything was olive oil. They took omega-3 supplements, and then, they bled out in the emergency room because it does have an impact on coagulation factors. So, also living in this world of more is better is not true, especially in IBD. And so as we start to close this evening's talk on malnutrition, I am fully aware that we are going slightly over time, and I very much would love to hear people's questions. We circle back to our patient who in nutritional status improved post-operatively, needed some additional nutrition interventions, but was able to get discharged home, drinking an oral nutrition supplement with the goal to advance to a healthy diet as tolerated, while we were mitigating obstructive risk in the short term. And so when we think about counseling and we really think about diets and nutrition and IBD, I empathize, it's overwhelming. People want more information and they really want a diet. They want a nutrition intervention that's just going to fix everything. We know that it doesn't exist, but we can still listen and reassure, and very much what I find is important is to have a consistent message on a team. Because if the team is saying different things, it can be very confusing depending on where the patient's journey is. So you want to be consistent in your messaging, and you want to make sure that it's targeted after you've had the opportunity to develop trust with the patient and to hear their perspective. This is just a standard kind of sort of how do we help someone eat well and how do we get them to eat healthy. You know, big, huge take home message this evening, you got to dump the junk. That is first and foremost, and you got to do it as a family. Don't forget too, this isn't a diet necessarily, it's a lifestyle. And as a part of living well, you want to ensure people are also sleeping well and physically active. So in summary, we know that there's a high prevalence of malnutrition and IBD. I think we all agree it exists. We're aware of it, but we want to know now how to be more proactive with it and how to help our patients with all the questions they have about diet, nutrition. So screening for malnutrition is key because that's where you can be proactive, not just waiting for, you know, there to be an inpatient dietitian assessment of the patient. You want to make sure that everyone on the team is engaged and that the appropriate nutrition intervention is advised at the appropriate time, whether that goes from IV nutrition all the way to healthy eating. So thank you, everyone.
Thank you, Inez, and thank you, Julie. Those were great talks. I'm sure we, you know, as nurses, we get asked all the time about diet. So I love the nutrition screening tools that you guys were talking about. You know, that website, I wasn't aware of the nutritional therapy for IBD website, and I took a peek at it. It's amazing. So I feel like our members are really going to love to be able to look at that and learning all about the differences between, you know, enteral nutrition, but also TPN. So thank you so much. In the interest of time, there's lots of great questions in the Q&A, and just so that we are able to keep on time, Inez and Julie have been so kind enough to offer that they will go ahead and answer the questions that are in the Q&A session. And they will answer those via email, and that will be sent out in our CANIBD newsletter, I think, in the coming weeks. So just so that we, so we'll kind of skip the verbal Q&A, and they'll be kind enough to just answer those questions via email. So thank you so much to both of you for taking the time to help us learn a little bit more about malnutrition and IBD. And I think with that, all of our attendees, we will let you go to break now for probably around 5 or 6 minutes. We're hoping to reconvene around 7:38 so that we can start right at 7:40, where we're going to hear more all about biosimilars. So thank you again. And everybody, we'll see you back at 7:38.
Welcome to the second portion of the evening. My name is Mary Louise Martin, and I'm a nurse practitioner with the IBD group at the Foothills Hospital in Calgary. For this portion of the evening, we have two speakers who will be discussing biosimilars. Dr. Silverberg will be presenting on what are biosimilars, and Amanda Swain will be presenting on the process of switching patients on established drug to a biosimilar. The presentations will be followed by a question and answer period, and questions can be submitted via the question and answer box. At this time, I would like to introduce Dr. Silverberg and Amanda. Dr. Silverberg is a professor in the Department of Medicine at the University of Toronto and staff gastroenterologist at Mount Sinai Hospital. He leads an active research program focused on elucidating the genetic and microbial contributors to the pathogenesis of IBD and to identify biomarkers relevant to its disease course. Dr. Silverberg is also actively engaged in educating healthcare professionals on IBD through his role as founder and past director of the Advanced IBD Fellowship Program at Mount Sinai Hospital for 15 years and co-founder of both the Canadian GI Fellows Program in IBD and Great Lakes IBD Forum. He is a member of the International Organization for the Study of Inflammatory Bowel Disease, past chair of the Scientific and Medical Advisory Board for Crohn's Colitis Canada and IBD section of AGA Council. He is also the founder and medical director of the Toronto Immune and Digestive Health Institute. After Dr. Silverberg, we have Amanda Swain speaking. Amanda graduated from John Abbott College in Montreal, Quebec in 1994 with a diploma in nursing. She worked as a registered nurse in the USA and England before moving to Vancouver to complete her Bachelor of Science in Nursing at UBC, graduating with honors in 2000. She has experience in a variety of specialties, ranging from working on HIV/AIDS inpatient unit and outpatient clinic at Chelsea and Westminster Hospital in London, England, to the neurology unit at BC Children's Hospital in Vancouver. In 2012, she took the position at Pacific Gastroenterology Associates in the endoscopy suite and infusion clinic, which then led to her current role as clinical IBD nurse at the IBD Center of BC. So I'd like to welcome Dr. Silverberg and Amanda.
Great, thank you very much for that introduction. And I'll share my screen now. Hopefully, just let me know if everybody can see it, hopefully. All right, well, good evening, everyone. Thank you so much for this invitation to speak to this group. I've spoken to CANIBD before, and I always enjoy it very much. And you folks are probably the most important people in the lives of IBD patients in Canada. So congratulations for all that you do, and thank you for having me speak. I was asked to speak about biosimilars. These are my disclosures, which are relevant to this presentation. So some of the essential questions that I'm going to try to cover: what are biosimilars in the first place, and should I use them? Should I really be comfortable using them, I guess, is a better way to phrase it. I'll talk a bit about their efficacy, safety and immunogenicity, the timing of when one might be switching, and other issues, which are actually maybe even the most important potential issues, and why they're introduced in Canada are the patient support programs, partnerships, costs, and economic impact. So you'll hear a lot of different names for biosimilars. In fact, in Canada, the official name that Health Canada used for these products is subsequent entry biologics, or SEBs. It's US that uses the term follow-on biologics. It's actually a European term, biosimilars. But in any event, biosimilars seems to have caught on, which is probably the most simple word to use. And it refers to biologic medication that is subsequent to or similar to an innovator or reference-based drug. So to just make it clear, Remicade would be an innovator product, and Inflectra would be the biosimilar. And the generic name for these products would be infliximab. So I think what's important to think about it, and often when we explain it to patients, the simplest way to maybe explain it is to just refer to biosimilars as generic drugs. But as a health professional, whether you're a nurse or a physician or other professional that's talking to a patient, it's important to know that there are significant differences between a generic and a biosimilar. So generics would refer to Tylenol versus acetaminophen and all the different types of acetaminophen you might see in the drugstore. So pills are generally small molecule drugs. They're chemically synthesized. It's pretty easy to characterize the compound that's in a pill or a chemical medication. Usually the mechanism of action is extremely well characterized and understood. It can be essentially duplicated exactly the active ingredient. What's sometimes different in generics are the fillers and the other things, but the actual chemical active medication is almost always identical. And they're approved based on relatively simple kind of chemical quantification and analytics of the similarity and bioequivalence of the product. So SEBs are different biosimilars. They're very large, complex proteins. They're manufactured in living systems. Remember, they're monoclonal antibodies, like vaccines, if you will. They are very challenging to fully characterize. So when companies make biosimilars, they don't get the recipe from the innovator company. They have to buy some of it and try to characterize it on their own through analysis of the product. It is very challenging to duplicate exactly, and the active ingredient is considered highly similar but not identical to, and that's just sort of an important thing to remember as a health professional. We're going to all get a bit lazy about that and say they're the same, but it is important to note they're highly similar, and they're approved based on a lot of non-clinical work, a tremendous amount, as well as a requirement for some clinical comparability testing, which is different than generics. So just to give you a little bit of an overview of how complex these molecules actually are. So remember, their proteins are made of amino acid sequences. So there's a lot of different properties. And for those that are closer to their undergraduate years, you might remember about the primary structure, the secondary, the tertiary, quaternary. There's a lot of different aspects. It's not just the amino acid sequence, and there's many different compounds that bind to these amino acids. There's glycosylation and fucosylation. And how each of these different types of biologics binds to its antigen is very unique to the product. So for an anti-TNF drug, it binds to TNF alpha, which is the pro-inflammatory cytokine that circulates, and it results in all sorts of downstream immune effects. So it is a much more complex drug. And in this slide, it's also important to sort of understand what goes on in drug development to maybe understand a bit about costs as well. So on the left, the upside down triangle is sort of how a new drug would be developed typically. So let's take Remicade as an example. When it was developed in the late 1990s, it would have been hypothesized that a product that could bind to TNF might be useful to treat inflammatory diseases. It will be characterized at a molecular level, understanding if we could develop an antibody that would bind to TNF. It would then go through a lot of non-clinical studies, say in animals and in laboratory models, in vitro models. And then it will go through a tremendous amount of intensive human research, going through the different phases of clinical trials, from phase 1, where it's tested in a small number of healthy individuals, usually for safety, and then phase 2 and phase 3 clinical trials, where it's put through more rigorous testing in larger and larger patient populations to ensure that it's both safe and effective. And this takes a tremendous amount of time, average probably 7 to 10 years to go through this process, a tremendous amount of money. And that's why these drugs are generally quite expensive. On the SEB side, you can almost flip the triangle on its upside down, and almost all the work is done on the molecular characterization. So taking that Remicade molecule and developing a similar product, a similar monoclonal antibody that will behave just like Remicade, and that might be Inflectra, for example. And so that's where most of the work is done. And then there'll be a little bit less on the non-clinical side. And then the actual human studies are a little smaller, a little less extensive, a little less well-powered, because it's felt that the characterization of the drug and making it very similar to the innovator drug is sufficient to feel that it's effective and safe. And you can imagine this process on the right is a little quicker and a little less expensive than the one on the left. So just as an example, and I'm not going to show you a lot of data because I think that will bore you, but this is just an example of what might be done at the end of the development of a biosimilar, is to compare its use to the reference product. So this was one of the first studies done with an infliximab biosimilar called Inflectra, and it was done in rheumatoid arthritis, and they would take patients with rheumatoid arthritis or IBD or whatever the example might be, randomize the patients to receive in a blinded fashion Inflectra or Remicade, and compare the outcomes. And generally, these studies would show fairly similar results. I'm not going to go into the statistical sort of arguments about how well powered they are. The study designs can be, a lot of people debate about showing superiority in these trials versus non-inferiority. And those are two slightly different concepts that involve how many patients would be required in the study to prove that. But generally, what these studies try to do is say, as long as these drugs are within a comparability margin of, let's say, 15 or 20%, then they're acceptably similar. So in other words, if the drug's 15% worse or 15% better, that's good enough. And people argue what that margin should be, but that's generally how these studies are powered. And they might have let's say 200 or 300 patients instead of 800 to 1,000 patients that are used in the registration trials. So this is, as I said, just some of the limitations of biosimilar trials. I'm not going to go into the details. I'm happy to take questions about it afterward, but there is some debate about this, but suffice to say that because of the significant amount of work done to characterize the molecule initially, there's less significance attached, rightly or wrongly, to the clinical trials. So another aspect to think about is extrapolation. So what that means is that for the example that I showed you, Inflectra, was tested initially in rheumatoid arthritis, and the companies often hope that if it works in rheumatoid arthritis, can we extrapolate that result to the other indications? So can we use it now for IBD, for psoriasis, for juvenile rheumatoid arthritis, for all the indications that the reference drug Remicade would have been used for. So this was also a subject of a lot of debate as biosimilars first came on the market. And in most cases, regulatory authorities like Health Canada accepted extrapolation. They allowed drugs to be extrapolated to all the other indications that the original drug was indicated for and proven to be effective for. But there was a little bit of a holdup in IBD, and I think it's important to remember that actually IBD is a little different than the other things that I mentioned. So rheumatoid arthritis, psoriasis, ankylosing spondylitis, some of the other inflammatory diseases behave a lot differently. I'll show you what I mean by that in a few minutes. But Health Canada in general did allow extrapolation, and they justified it based on the mechanism of action of the drug, the fact that many of these diseases have a similar pathophysiology, and looking at the safety profile and clinical experience, for example, with Remicade having been effective for all these indications, Health Canada assumes that it would be effective for all the other inflammatory diseases. But this slide is kind of my way of reminding you that IBD is different. So if you look at the bottom right, this is a picture of an inflamed joint. Rheumatoid arthritis might look like this, or ankylosing spondylitis. So the joint surface and the amount of systemic inflammation is significantly less in the body than, for example, IBD. And if you look on the left, the lower left, that's an example of psoriasis, which might be treated with infliximab, and compare that burden of inflammation to a colon affected by Crohn's or ulcerative colitis, like you see on the top pictures. You can imagine that the inflammatory load that these patients have to deal with is significantly greater than the ones on the bottom. And so the dosing becomes different, and the way the drug behaves is different. The rate of antibody formation to the drug might be different. And so this led Health Canada and other regulatory authorities in some countries to request of the companies to do IBD specific trials, just because of that fact that IBD does behave differently. Loss of response rates might be higher, and immunogenicity, like I mentioned. So these are important things to remember when you're sort of trying to interpret what to do with these types of data. And here's the issue with so antibodies was the biggest concern. All of you would be familiar who manage biologics will know that especially anti-TNF drugs are very prone to immunogenicity, to causing antibodies against the drug. And when antibodies form, the drug becomes ineffective in the vast majority of cases. And so people were concerned about, will a drug like Inflectra, as an example, infliximab biosimilar, Remicade biosimilar, cause more antibody issues than the originator drug? And so this was a subject of very intensive study, and it's been studied in the adalimumab biosimilars. And in general, basically every study, and this was one of the most intensive ones that was done by an Israeli group in 2015, they really did intensive cross-reactivity of patients who developed antibodies to the different drugs, and then tested whether patients would have the same type of antibody reaction if they switched from Remicade to Inflectra, vice versa. And it basically showed that the antibodies against either drug would neutralize either drug. And if a patient was exposed to the alternate drug, so for example, if a patient got Remicade, was taking Remicade and had antibodies against Remicade, and then we're exposed to Inflectra, Inflectra would be just as ineffective as Remicade. So it's so similar that antibodies against one affect the other. So that's important. And the antibodies against Inflectra would also affect the response to Remicade. So you have to think about these drugs as identical from a patient care perspective. If a patient's been exposed to one and it didn't work, think of it as if they were exposed to all the other infliximab products, and the same applies to adalimumab as well. So these are very specific effects of these drugs are so similar that you have to really consider them identical from a patient care standpoint. So if they're that similar, then we start getting into this issue of interchangeability and substitutions. And these are really, I don't think these are too important for this audience, but really just to remember now that with generics, when a patient goes to a pharmacy, the pharmacist has the authority to substitute the product. So if you put a penicillin, whatever, I can't think of a trade name for penicillin, but if you have a specific antibiotic with a specific trade name like Flagyl, for example, you go to the pharmacy and the pharmacist has the right to switch it to apometronidazole, and we all think of that as no big deal. So will that apply to biologics? If we write a prescription for Remicade, will a pharmacist be able to sort of swap that out for Inflectra, or vice versa potentially? And so in general, these concepts means that they're considered equivalent enough that you don't need a physician to decide which one you get. And fortunately, Health Canada has decided most countries, most but not all countries, have followed this approach where they can't have automatic substitution without a physician's instruction or the patient's consent. So just to, again, sort of help you remember the names of some of these products, and I've just sort of listed them. I might not even be comprehensive in this, but to my knowledge, best of my knowledge, there's 3 infliximab biosimilars available in Canada: Inflectra, Renflexis, and Avsola. There might be others that I haven't heard about or may have been introduced more recently, but these are the 3 that are out in Canada. And again, reminding you that these are biosimilars of Remicade. For Humira, there's even more, so it gets a little more complicated. There's quite a few companies worldwide working on adalimumab biosimilars. Humira is the innovator product, and that's because it's probably by far the largest by volume anti-TNF worldwide. And in Canada, it's probably a little bit more on with infliximab, but worldwide, adalimumab is a huge product, as I'm sure you can imagine. And these are some of the ones that are out in Canada and the companies that make them. There's 5, again, to my knowledge: Hadlima, Idacio, Amjevita, Hyrimoz, and Julio. All sort of creative names there. And there's a Pfizer one that's also, I'm not sure if it's available or it's coming, and I don't know what the name of it is, but so there potentially will be 6 in Canada pretty soon. So this raises other questions about biosimilars when there's so many. And adalimumab being a subcutaneous injection and a pen, there are some slight differences, which I'm not going to go into in the presentation, but I'm happy to talk about them in the Q&A. But some of them, and you're all, I'm sure, a bit familiar with some of the, let's say, stinging that some patients report with Humira, speculated to be related to citrate in the drug, a preservative. Some of these biosimilars do have citrate. Some of them are citrate-free. Some of them have refined the needle to a finer gauge, so it's supposed to be less painful. Others of not, our look would just be similar to or exactly like Humira's pen. So there might be subtle differences here, whereas in the infliximab biosimilars, I really don't feel there's anything remarkably different about the drug. In this case, if you do believe that citrate is an issue for your patients, you might want to investigate that sort of thing and think about which pen, try different ones, see which one your patients like better. So I wanted to sort of, now with so many adalimumab biosimilars available, it now becomes potentially interesting about switching. So I'm going to leave Amanda to address this in more detail because she's got direct experience with this. We're actually in Ontario. We haven't had a lot of mandated switching, so I have very little practical experience. But the data on this could potentially be confusing because some of the switch studies really just switched people from the reference to the biosimilar one time and said, well, we switched them. They were doing fine before, they're doing fine after. These are okay. But the concern is that, let's say, taking Humira as an example, and you could potentially have a situation where a patient started on Humira, doing well, was switched to Idacio, and then 6 months later switched to Julio, and 6 months after that switched to Amjevita, just because the payer, the insurance provider, the government has a contract now with a different company, and they can get it for a less expensive price. So suddenly you might have multiple switches of all different compounds in the same patient who's doing fine and happy on whatever they're taking. And the question is that going to cause problems? So there aren't a ton of studies with multiple switches, but there are some that have started to be published. And so far, I think the most I've seen in IBD is sort of 2 switches during the maintenance period, and not seeing any strong signals of any problems. But again, remember, these studies are not very large and not tremendously well powered. So how much will we allow as a in health regulatory bodies, payers, as physicians, as nurses? Is there going to be any limit to this or controls on this? We don't really know how that's going to go. So before you get too concerned about that, I think one thing that's also important to remember is that there is a concept called drift with biologics. So because I mentioned at the beginning, these are proteins. They're manufactured in culture models, so they're live cell cultures that, as the manufacturing goes along over many years, it is conceivable that these molecules may change a little bit in these complex structures. And it is speculated, or maybe even proven, that if we looked at, let's say, Remicade back in 2001 when we started to use it, and now 20 years have passed, the plant that Remicade's manufactured in probably has changed. The culture, the cells that are derived to manufacture it have probably changed. And so it is conceivable that Remicade of 2001 looks quite a bit different than Remicade of 2021. It still has to go through a lot of rigorous testing and quality control, and that's all controlled by the company and inspected periodically by regulatory authorities. But I would say it's pretty likely that Remicade of 20 years ago is probably a little bit different in subtle ways than Remicade of 2021. And that maybe should reassure us that if patients are switching multiple times to a biosimilar that might have slight characteristic differences compared to the originator drug, that it might not matter too much. But we don't really know, and this picture just kind of illustrates the concept that I just explained, that there's manufacturing changes, there's changes in the way that the drug is produced over time that could result in subtle differences to biologics. And this just shows actually some of the manufacturing changes during the life cycle of some drugs that you're familiar with, like Remicade. You can see actually well over 30 manufacturing changes, and Humira had well over, or around 20. Data is actually 10 years old, so it's probably even more than that by now. But it's just to illustrate that these are complex drugs that are not going to be identical all the time forever. So again, and just, I referred to a switching study. Just in theory, I'll just show you one example of a switch study and the data around it. So this was called the North Switch study, which was done using Inflectra and Remicade. And just to show you the study design for a switch study, they would take patients who were stable on Remicade, as an example, whatever the disease indication was. In this case, they looked at all the disease indications that Remicade is used for, like RA, psoriasis, IBD. And they just randomized them in a blinded way to continue on their Remicade or switch to Inflectra, or it's also known as Remsima in other countries to make even more confused. And then they would have an endpoint at a year, and then they would do a switch where they would switch the people on Remicade to Inflectra or continue on Inflectra. And they just look at the data over quite a long period of time. This was a 78-week trial. And again, lots of different patients. And what they showed overall, just to give you a sense of it, is that looking at an outcome of disease worsening, 26% of the patients who just stayed on their Remicade got worse during the study period, and about 29% who were switched got worse. So the difference was very small, not statistically different, and that therefore it was concluded that these drugs or switching patients doesn't lead to any concerning issues. And again, but you can see the sample size isn't particularly large, and the power to detect a difference is not that high. The difference would have to be quite large to find this meaningful difference. And the other question about antibodies, would switching lead to more antibody formation? So in this study, even after switching, about 7% of patients had antibodies in both groups. So it didn't seem like, at least initially, there was an issue with antibodies or infusion reactions with the switching. So to conclude, I remind you, what's the reason we're using these? Well, it's all about cost, almost exclusively. I sort of facetiously put the title of Gastroenterology is contributing to a financial healthcare crisis. This data come from the United States primarily, but it's probably comparable in Canada. If you look at the global spending on drugs, it's gone through the roof. And Humira and Remicade are sort of in the top two positions, at least at the time that this was published, probably not too different now. So these are very expensive and very highly used drugs because they're very effective drugs. So we do have to think about costs, especially in Canada, where we have a public healthcare system. And this sort of suggests that with a switch from Remicade to Inflectra, just in theory, there could be upwards of $400 million worth of savings in Ontario. And I think there's already some data showing the significant savings from BC, Alberta, where switching has been happening for a while, and what that might mean to the healthcare system with very significant cost reductions in paying for these medications, both for public payers as well as private payers. So to conclude, what are the pros and cons of having biosimilars in our healthcare system? Well, as I was just saying, the pros are definitely cost savings. There's no question that's by far and away the greatest benefit. Is competition for services a pro or a con? I'll leave that to you to decide. Sometimes it just could be a race to the bottom rather than a race to improve and compete for the patients. Technically, it should improve access, but I'm not, and I know that has happened in Spain, for example, where biosimilar adalimumab is extremely cheap compared to the innovator Humira. But in Canada, I wouldn't say biosimilar of any biologic is extremely cheap, and I'm not sure we're improving access other than by saving money for the healthcare system. And I would say that there's generally a positive experience from other countries. So whole countries, especially in Europe, have switched over. Norway, in the UK, Italy, Hungary, and there's been a lot of data published from these countries where entire regions and populations have just completely switched people from Humira to an adalimumab biosimilar. And all the data that comes out of these places in general shows no major concerns. The physicians who've got a lot of experience with this have not seen any signals of any concern whatsoever. So that's probably the most reassuring, is the real world, huge data sets that we're seeing don't show any concern. However, on the flip side, maybe we'll get less services from the patient support programs, although I would say to date, and to their credit, just about everyone that I'm familiar with has maintained the same level of service, or at least is trying to maintain the same level of service as the primary PSPs. For a patient, they're changing from what they're comfortable with. They might be dealing with a bioadvance coordinator who they've known for 15 years, and asking them to switch might be a stressful event, an anxiety-provoking event. There is going to be variability for sure in the quality of the PSPs across, let's say, all the 5 adalimumab biosimilars. I mentioned the relative lack of data, the nocebo and patient anxiety effect. I didn't really talk about, but it's simply nocebo means it's sort of the reverse of a placebo effect, that just by nature of the fact that you're switching a patient, they feel worse and they start, expressing symptoms that maybe are more psychological or anxiety related rather than real. And I'm sure we'll hear a little bit about Amanda on that. And the last thing I'll say, and I've said this repeatedly to so many people, is who's benefiting from the cost savings. So if Ontario, for example, saves $400 million, is $1 of that going to come to the IBD patient population? Is it going to help us with mental health care, with nutrition services, with more accessibility to endoscopy, to experienced gastroenterologists, to nurse funding? So far, I would say the answer is no. So to explain to a patient, well, you're doing this because it's saving costs for our healthcare system, but sorry, we don't know who's actually benefiting. Is it just going into the big healthcare pot? So I try whenever I can to advocate for savings, for at least to come back in part to some type of program that helps IBD patients, but I haven't had much success in that regard so far. So thank you. I'm happy to turn it over to Amanda. I'm interested to hear her take on this.
Thanks, Dr. Silverberg. That was a great summary of the data, and I think it leads well into my talk, hopefully, which talks about the experience of switching to biosimilars and my experience working in BC. Next slide, please. These are my disclosures. Next slide. And so the objectives for today's talk are to examine how the switch to biosimilars began, review the process to change to biosimilars, and then just to discuss the successes and failures of the transition to biosimilars. Next slide. So how did this all get started? Well, Remicades' patent ran out in 2018, leaving the market open. And this essentially allowed room for the new kids on the block, the biosimilars, to enter the market and compete. And as we know, biosimilars are biologic drugs that are highly similar to the originator drug. They're manufactured to the same regulatory standards as other biologics. And they are as effective and as safe as the originator, but are approximately 40% cheaper. There were 2 options for infliximab biosimilars available and approved by Health Canada: Pfizer's Inflectra and Merck's Renflexis. Initially, we had the option when starting patients on infliximab to start them on Remicade or a biosimilar. And at this point, the biosimilar companies really reassured us that when the time came for the switch, that the patient support programs would be ready. Next slide. But change is difficult. So although Health Canada had approved 2 infliximab biosimilars, we continued to start our new infliximab patients on Remicade. After all, we had a really good working relationship with the Remicade PSP program. We loved and we still love our patient coordinators, so why make a change if we didn't have to? This may not have been the right approach, given that the change was definitely coming, but it seems as humans, we often prefer to stick to what we know. And certainly for patients, they preferred to stay on the medication they were currently on. And for new starts, as I said, we continued to do Remicade. Next slide. Then in July of 2019, before the switch was even announced by the government, we started to get emails and calls from patients telling us they'd received a letter that came from Janssen advising them of the likely upcoming non-medical biologic switch. And this letter advised them, among other things, to reach out to their GI to discuss the switch and advised them that their GI would be able to write a letter on their behalf to PharmaCare to request that they stay on Remicade. And this caused a huge amount of anxiety amongst patients and provided them perhaps with a false sense of security that their GI had control over deciding if they would have to switch or not. The official government announcement was then released, and non-medical switch to infliximab biosimilar was indeed moving forward, whether we were ready or not. And if patients were to maintain government funding in the way of PharmaCare coverage, then they had to switch by the deadline, which was March 6, 2020. They rolled out the switches in phases. Phase 1, which took place from May 27th, 2019 to November 25th, 2019, did not affect our IBD patients. They started the rollout with the rheumatology population first. Phase 2, which was from September 5th to March 5th of 2020, a timeline of 6 months, PharmaCare changed the coverage for patients with Crohn's disease and ulcerative colitis so that all 3 brands would be covered. But after that deadline, patients would have to have had switched. Next slide. So in BC, much like other provinces, when patients are started on a biologic, the PSP program helps to ensure coverage through the government program, PharmaCare, and as well through the patient's extended health insurance if available. The PSP program also, they have a variety of programs to assist patients such as bridging, copay, and compassionate drug. It's a complicated system that requires reapplication to PharmaCare for approval for continued coverage on a yearly basis. And that means a lot of paperwork that needs to be in place. With the switch, if patients had coverage for Remicade, then this would also cover the biosimilars. If their special authority had expired, then an application needed to be made for an approval of a biosimilar. Next slide. So in an attempt to help, the government did provide information online and as well a printed booklet entitled Biosimilars Initiative, Prescriber's Guide. And it was a comprehensive tool that outlined the reasons for the switch, provided the timeline and deadlines, and discussed how to speak to patients about the switch. And it even gave a list of the new infusion clinics for both biosimilars. Next slide. But despite the well-laid plan from the government, the news was, as I said, highly anxiety producing, really for everybody involved. And the reality of implementing the switch was daunting. It was chaos, really. And just to give you an idea of the workload, within the practice, we have had and have 12 doctors with 2 full-time dedicated IBD nurses. I should know that out of the 12 doctors, there's 3 main IBD physicians, but still the other doctors did have quite a few IBD patients that would need to switch to an infliximab biosimilar. And essentially in a period of 6 months, we needed to switch about 500 patients. And this was an immense increase in the IBD nurse workload and everybody's workload, but particularly the IBD nurse. So the reality was that the clinic received an immense increase of volume of phone calls and emails about the switch from patients. Patients were understandably worried about the upcoming switch, and it came as a shock to them. We were the first province to do this, and a lot of people, it just was not on their radar. So like I said, our phone lines and emails were just bursting with questions from patients concerned. There was a feeling of being betrayed by the government and let down by the healthcare system. And this resulted in anger from some patients towards their IBD team. This was particularly difficult for patients that had been very sick and were finally doing well on Remicade. The prospect of switching to a biosimilar was terrifying, and understandably so. As a result, this led to the nurses feeling overwhelmed, and honestly, we all felt a bit burnt out. Meanwhile, the government did implement some changes to help the transition. They implemented a biosimilar patient support fee, a $50 fee that was billable to MSP. And this was offered in recognition of the additional effort involved in contacting patients and supporting their switch to a biosimilar. This fee could be claimed once per affected patient during the transition period, regardless of whether that patient switched to a biosimilar or not. Gastroenterologists were also able to bill MSP for nursing staff to support care of patients. This was a $60 fee payable once every 6 months for patients with a confirmed diagnosis of Crohn's disease or ulcerative colitis. And as of August 2019, fecal calprotectin stool tests were made available to all IBD patients on a biologic through Life Labs, free of charge to patients. And now actually it's available to any IBD patient. So to begin the process of switching patients, we were able to get a list of patients from the BioAdvance support program, which was really, really helpful. Each physician could also request a list of their patients that were currently on Remicade from PharmaCare by faxing them a request. Most physicians, with the help of their MOAs and the IBD nurses, tried to bring in the patients for an appointment in order to discuss the switch. But as the deadline loomed, this became more and more difficult. And so a lot of the discussions, counseling around the switch, they were completely done over the phone with the IBD nurse. The nurse's role was key to the entire process. We counseled patients about the non-medical switch, explained the rationale, risk, and safety. As there was no communication between the PSP programs, so we had to ensure the smooth handing over of the patient's information. So we coordinated the paperwork, providing copies of the latest special authorities and Remicade orders to the biosimilar PSP. And we also let them know when they were next due an infusion. And we tried to give them lots of time, although near the end, again, it was a little bit of a rush and we had less time to get patients switched. And then, as I mentioned before, we fielded calls and emails, again, answering questions and easing anxieties. And I'm going to get to the approach we took when counseling patients, but I did first want to talk about the nocebo effect, which Dr. Silverberg also mentioned. We are all familiar with the placebo effect. Oh, next slide, please. Next one. Thank you. We're all familiar with the placebo effect, in which a sugar pill has the same effect as the active medication. Well, there is a similar phenomenon that's worth being aware of when we start talking about the switch, and that's called the nocebo effect. And the nocebo effect is how the expectation of pain or negative effects of a treatment increases the chances people will feel them. So even if there aren't any, so tell someone that a treatment will hurt and have side effects, and they're now more likely to feel that pain or find something wrong. So taken together with the placebo effect, it's likely best to let people know that what they will get, in this case, a biosimilar, will probably help them rather than raise worry, which could lead to a nocebo effect failure to the biosimilar. Next slide. So many factors can contribute to the patient's likelihood of experiencing the nocebo effect. Mental health comorbidities, especially anxiety and depression, which of course is a huge issue with our patient population, and history of negative interactions with the healthcare system. Practitioner factors such as language choice, manner, nonverbal communication, or an unbalanced focus on the potential negative adverse effects. Healthcare setting factors such as the physical environment, comfort, ease of access, and interactions with other staff and patients. And, that many patients, or most patients, did need to move from the clinic they were getting their Remicade and go to a new clinic. So that was certainly a factor for our patients. Drug factors such as the appearance or smell, administration route or routine, change in delivery, labeling, pricing. This drug's half the price. Would that make some people think that it was less effective? It brings us to some of the common patient concerns. Will this drug work as well as Remicade? What happens if I flare? Can I switch back to Remicade? Many people didn't want to move to a different infusion clinic. Next slide. Next slide. So taking into consideration the nocebo effect, the approach we took was a positive one when we were counseling patients. We validated patient concerns. Understandably, they didn't want to switch. As I said earlier, this was particularly hard for those patients that were finally stable after a long period of being sick, and now they were being asked to switch. We tried to balance the discussion when discussing the desired effects of the switch versus the adverse effects of switch. For example, we let patients know that the data from Europe was reassuring, that the majority of people, if stable and doing well, continued to do so after switching. We explained that the flare rate after switching was no different, meaning there was no signal of a huge spike in the number of people flaring or losing response, that rate remained the same when we looked at switch patients. We empowered patients to be a part of the decision with regards to which biosimilar they would switch to. And really, there was no differentiating factors except the infusion clinics. So we would have patients look at the list of infusion clinics to see if there was one that had a preferable location over the other. As well, one company had more weekend infusion clinics open, so this too helps as a deciding factor. But if patients had no preference, then we basically, would choose one or the other. And certainly we had a similar experience between both PSP programs. So it's not like one was better than the other in our experience. So, and then we also set expectations, and we explained to patients what the next steps were, such as expecting a call from the new coordinator, that it would be a similar experience to when they were initially enrolled with the Remicade PSP, and that it would be the PSP program that would book their next infusion. Next slide. Patients for the most part were reassured by this counseling process, but there were obviously some difficulties with the switch. Although we did receive reassurances that the patient's support programs were ready for the onslaught of new patients, in reality, the volume was too high for them to be able to manage. And this meant there were many delays with infusion scheduling. We received many calls from patients stating that they were 2 weeks overdue and had still not heard from the patient support program. And in many cases, we'd provided ample time to get the patients switched. We just didn't have enough staff to manage the workload, I think. And these delays caused further volume of calls and emails from patients to the IBD nurse, worried that they'd not heard from the patient support program. Another complication was that Remicade stopped providing compassionate dosing. So we had the double whammy of no more Remicade available and delays with the overwhelmed biosimilar PSP. So there was delays in getting people onto their biosimilar infusions. Many patients were more upset about having to move to a different clinic, leaving the nursing staff that they'd known for years, that they trusted, who were able to get that one spot, get an IV started in that one spot, or to leave a location that was really convenient to them. Next slide. Of course, there were many things that did go well. Most patients really did understand the rationale for the switch. And once they'd been counseled and reassured, they were really very comfortable moving forward. The new patient support programs matched the old one when it came to covering deductibles, providing compassionate dosing, and bridging. They also offered services such as therapeutic drug monitoring and fecal calprotectants were also offered, again, quite comparable to the Remicade patient support program. And luckily, we did complete the infliximab switch right before the next challenge started, which was, of course, the COVID-19 pandemic. Next slide. So some of the outcomes, well, as expected, the majority of patients did very well. And after the initial delays with getting biosimilar infusions scheduled, and as the volume of switches settled, the PSP programs were able to adjust, and they brought on more staff, and overall, they just became better equipped to support patients and the healthcare providers. It's estimated that 12 to 18% of patients are expected to lose response from therapy each year, and the loss of response following switch was found to be comparable. Patients did flare after the switch, perhaps because of the nocebo effect, maybe because they had poorly controlled disease prior to the switch, or maybe simply because of a result of the nature of the disease. Unfortunately, patients were unable to go back to Remicade. They basically stipulated that they would have to fail a second biosimilar before they would approve Remicade again. So generally, if they were failing, we would, switch out of class, and also considering that we're looking at Remicade and a biosimilar as being very similar and comparable, then if you failed Remicade, if you've switched from Remicade and are now on Inflectra, for example, and had a loss of response, then you've essentially lost response to infliximab. So it would make, I guess the rationale is that it would make more sense to switch out of class. Next slide. So take two, here we are again, this time with Humira. And the switch deadline for Humira has now passed. That was October 6th. And we still have a few patients that haven't switched yet, but I think the majority of our patients are now on a biosimilar. So we had a similar amount of time and similar number of patients to switch, but for a variety of reasons, the transition seemed to be much less stressful. And maybe it's because the switch happened during a global pandemic and attentions were elsewhere. Maybe because patients are more familiar with biosimilars now. It's been out there for a while, and maybe because the Humira patients didn't receive a letter that sort of made them anxious. It's hard to say, but all in all, the process was a lot less stressful and has gone a lot smoother. I guess one of the reasons might be this time around for us certainly is that we were lucky to make some changes to our staffing that lightened the workload for the nurses. And that was bringing on a pharmacy team. So we have the addition of a pharmacist and 2 pharmacy technicians, and they've been really key in helping us to liaise with the patient support programs and help with that communication. They're also helping to complete the special authority requests. And so that's really been wonderful in helping. As a result of the pandemic and the necessity for e-signatures, we now have all the enrollment forms in our EMR system. And this has been huge in decreasing some of the steps and the back and forth between the PSP and getting doctor signatures and sending it back. So that certainly helped to streamline things. And then, AbbVie has also been very generous in continuing to provide compassionate Humira while we get patients switched over. And that certainly provided us with a little bit more wiggle room when switching and getting people organized to switch to biosimilar. Next slide. So I think there are many more options available, but in the world certainly for Humira biosimilars, but the ones that I'm aware of and are these, the Amjevita, Hadlima, Julio, Hiramuz, and Idacio. Our office has been dealing mostly with 4 of those options, simply because of not having a contact for any PSP or anything for one of them. So it certainly makes it more difficult when trying to decide which one to choose. There's no differences between efficacy, safety, immunogenicity when compared to Humira and amongst them all. Again, there's no IBD studies currently. Much like the infliximab biosimilars, outcomes have been extrapolated from the RA population. So how do we choose? I mean, some factors to consider, and there are some differences between them. Similarities, they all have pretty similar PSP programs, the financial assistance. Oh, next slide, please. Financial assistance is all pretty similar. Injection training and support is all similar, and they do all offer the TDM, the fecal, the TB skin test, and the IGRA test as well. What differentiates some of them is the citrate-free options. Amjevita and Julio are 2 of those. Hiramuz has less citrate, I believe it's 84% less. And it also has a longer stability out of the fridge, 21 days. And there's the needle gauge differences, smaller needle gauge. Julio is one of them that has that on offer. And one of them didn't have initially, I think it was Idacio, didn't have a pre-filled syringe option, although that's changing, I believe, and that is going to be offered. So, and then they're not all indicated for pediatrics, which is not pertinent to our practice, but for others it might be. So how's it going? Well, as I said, it's crunch time and the deadline has passed. But as I said, the overall experience with Humira switch has been much calmer. And as a whole, patients have been much less resistant to the change. and everyone's working hard to get things in place so that everybody's switched. And if we had to do it again, perhaps some preemptive communication from our office would have been helpful. It certainly could have potentially cut down on the volume of calls. More time, 6 months really, particularly for the Remicade switch, was just not sufficient. And it, like I said, it was difficult to get everyone in and have that conversation with them in that time. I know there's constraints, but additional staff to manage the increase in work volume. This time around, as I said, with Humira, we did have that with the pharmacy team, and it's certainly been really helpful to our workload. But, additional nursing staff could also be very beneficial. Next slide. And just in summary, switch, I think we can safely say is inevitable. Certainly BC, where we've done it now for two drugs. And I expect that the rest of Canada will probably follow suit. You can anticipate some short-term workload increases. And I think our approach as healthcare providers can really help to ease the anxiety caused by the switch. And, keep in mind the nocebo effect when you're choosing your words and speaking to your patients about the switch. Obviously, the IBD nurse is key. And, but overall, patient outcomes are good. And that's certainly been our experience. So thank you very much.
Thank you, Dr. Silverberg and Amanda, for fantastic, informative presentations. We have a few questions for our audience. Dr. Silverberg has already answered a few in the comments. Thank you very much for that. It does help with our time crunch we are encountering. Our first question from the audience was wondering if the IBD nurses are allowed to have those conversations with the patients, or if they have to come into the clinic or talk to a physician by phone. And if there's any difference between how it will be done in BC and Ontario.
Mm-hmm. Like I said, we definitely tried to get them in to see the physician, but we did run out of time. And so the nurse, I think the nurse is very capable of having that conversation. And if patients were not satisfied with that, then we would make an effort to bring them in to talk further with the physician. Yeah, so it's a team approach.
Dr. Silverberg, do you know if nurses, I think the person who posed this question is from Ontario, the nurses will be able to gain consent for the switch over the phone, or are they going to have to come in and talk to you?
I have no idea. We have not been given any information yet on how this is going to happen, and it just keeps getting pushed further and further down the road. So now I'm hearing it won't happen till June of next year after the next provincial election. So who knows?
Thank you for that. The next question is for Amanda. How do you think we can best prepare and support patients and families in a switch from originator to the biosimilar? Do you have any pearls or websites you can refer people to?
I don't have any particular websites. I mean, I think I've gone over how we approached it and what seemed to work. So I'm not sure I have any more to add to that. I think the positive approach was, the way to go. Obviously, you're going to get pushback from some patients, and it's understandable. It's not going to go well with everybody. But I think just listening to people and hearing them out and then trying to present the information in a positive way.
Thank you. Next question is for you, Amanda, as well. Do you think $50 per patient switch is a sufficient monetary reimbursement for the time the nurses spend? And someone actually had a follow-up question for that, and they were wondering, were the funds that were paid out for this code put back into nursing or education for the nurses?
In terms of the billing from our office?
Yes.
Or in terms of the provincial
I think it's for both. I guess, have you seen any improved educational resources for yourself or services for your patients?
Well, we're pretty lucky. We have a lot of educational opportunities, so we're well supported from that. To be honest, I don't know exactly where those funds went to, but yeah, I don't really have any more to add.
Okay. Yeah, thank you for that. And then another question we have is, with the adalimumab switch, did you find the patient's individual pharmacists were helpful in providing education on the switch to the patients, which may have also reduced your educational / support burden?
It's possible. I know we certainly would get phone calls from patients that said, my pharmacist told me I need to switch. So the conversation was already started at the pharmacy in some situations. So yes, I do think that partly helped.
Thank you. And I actually have a question from my experience in Calgary. In Alberta, we had the exemption request, so they could request their care provider to fill out that form or write a letter to remain on Remicade. I was just wondering if you ran into the same thing in BC, what your approval rate was, because in Alberta it was quite low, but it was very time consuming for us as nurses and healthcare staff to write those letters. So do you have any advice for healthcare staff that may be asked to write the exemption letter? We didn't write very many because really that's a difficult thing. I think it's a difficult thing to start. And as you said, the workload there starts to increase. And how do we decide should this person be exempted versus this person? So it's a bit of a slippery slope, but we there were a few that were written, and I didn't have very much success. So there was a very low rate. Another question, just based on my experience in Calgary, before the pandemic, did you do any group educational sessions? We had a few in Calgary, and depending on the group of people that are there, someone turned out to be very angry situations where everyone was angry about the switch, and other ones turned into supportive. So I was just wondering if you guys had experience with that, and if it's something you might recommend. With COVID, it could be done via webinar now instead.
We've never done that, but I know we've talked about doing different group like counseling and activities, but we haven't tried that yet. But I think partly we have the experience of having the infusion clinic in our old office, anyways, and that was kind of our experience, that depending on the mix of patients that were in the infusion room, it could either be very positive and supportive or very negative. So yeah, that's interesting.
Our last question is in regards to switching. Was everyone in BC required to switch, or was it only the people who were on the public insurance? So just wondering if there's a difference between private patients and public.
That is true. So if there's particular extended health plans that would continue to cover Remicade or Humira, and so those patients were able to remain
on the originator.
Yeah, right. Or if they were also with Remicade patients, if they were on completely compassionate, then they too were able to stay on Remicade.
Fantastic. Great. Thank you both very much for your time. That's all the time we have for tonight. Both very informative talk, and hopefully going forward, people will be able to take some of the pearls of wisdom you shared to help ease anxiety for their patients. I'll now turn the meeting back to Kelly, who will wrap us up for the night.
Well, hi, folks. Wow, what a wonderful evening, and some great presentations and conversations there. And certainly here in Nova Scotia, you were able to stimulate. There's 3 nurses here online from Nova Scotia, and we all started talking about, are we ready for this switch, and how are we going to prepare for it? So it was really interesting, the conversation you prompted. I want to thank all of our speakers from this evening. It was very informative, and certainly I thoroughly enjoyed it. And I want to thank all the participants as well for being such active participants and for asking questions and for certainly staying with us on what is, well, for most of us, a long evening after a long day. Okay. So next slide, please. Oh, I already thanked everybody. I guess I don't have to do that anymore. So please remember the other thing that I have to ask you to do is to complete your evaluation survey, which will pop up at the end of the Zoom meeting. And it's really important that we know if we're on the right track in terms of providing the information that you all need. And it really helps us, it helps feed our decisions in terms of how we move forward. Next slide, please. Again, these are our sponsors, and we want to thank them very much for their contributions to CANIBD and to our ongoing programs for education and mentorship. And without them, this all wouldn't be possible. Next slide, please. And again, you can stay connected to us through Crohn's and Colitis Canada, the CANIBD website. You can email us at canibd@crohnsandcolitis.ca. We are on Twitter, and sign up for our newsletter, which you can receive as part of CANIBD. Thank you again very much for everybody for attending. Next slide. I think that's it. I'm finished. And thank you all again, and we'll call it an evening.